Welcome back, everyone. We're going to continue our discussion of the airway, and this time we're going to talk about basic special considerations and foreign body airway obstructions. Yet another airway acronym for you, FBAO, stands for Foreign Body Airway Obstructions. And while you're going to talk about the removal of foreign body airway obstructions during your BLS class, we're going to mention some considerations here and discuss it as a brief overview. First of all, let's talk about some special airway considerations for patients that you may encounter in the field as an EMT. Stomas and tracheostomy tubes are a fairly common occurrence that you may see when encountering patients in the field. These are patients who have had a laryngectomy or have a permanent tracheal stoma known as a tracheostomy. And this is a surgical procedure where a breathing tube was placed for the patient to use as ventilation assistance over a long period of time. These patients may have previous pathologies such as oral cancer or facial cancer where the functions of the upper airway are not working appropriately, and thus they ventilate into and out of that stoma or opening. While this might be intimidating as you encounter it in the field, the basic principles of ventilatory management and oxygenation are exactly the same. Stomas and tracheostomy tubes do have some considerations on opening the airway, though, because neither a head tilt or jaw thrust maneuver is going to be effective in opening the patient's airway, because the opening moves directly into the trachea, into the outside world through that os or opening. The most common airway complication that you're going to see, or the intervention that you'll need to perform, is indeed suctioning of that stoma or opening. If the patient has a tracheostomy tube in place and you need to assist ventilations, you can ventilate with a bag valve mask that will connect directly to that tracheostomy tube or that opening, the tube that's placed in the opening. For patients that have a stoma but no tube in place, you can use an infant or a child-sized mask with your bag valve mask to make a seal with the neck as opposed to the face over the stoma to ventilate. If you can't ventilate through the stoma, you may need to suction the stoma. Try suctioning the stoma with the use of a French tip or soft tip suction catheter device. And if in the event that you're giving mouth-to-mouth ventilations, or preferably, since we use personal protective equipment and practice body substance isolation in medicine, you would be delivering mouth-to-mask device, you will need to occlude the stoma while you're delivering those ventilations. Under no circumstances should you be giving mouth-to-stoma ventilations, as that completely violates the principles of body substance isolation and utilization of personal protective equipment. Let's talk about airway obstructions. If an obstruction completely blocks the airway, this is indeed a true emergency. As we've discussed in the ventilation and respiration and oxygenation lectures, respiration and oxygenation are essential to life, and if a patient can't ventilate, they will not survive. For adults, this typically occurs during a meal where a food has occluded the airway. In a child, though, it can occur while eating or playing with small toys or crawling. Reminder that the number one airway occlusion that we deal with in EMS is indeed the tongue, and we've learned about some devices we can use to assist this. We have a couple of procedures to help move the tongue out of the oropharynx to keep it from blocking the airway, and that's the head tilt or chin lift, head tilt, chin lift, and jaw thrust maneuver. We also have some tools that we can use, the oropharyngeal airway, the OPA, and the NPA, which are both classified as simple airway adjuncts. Causes of airway obstruction that don't involve foreign bodies can include things like swelling of the pharyngeal tissue. This is common in acute allergic reactions, or in trauma if there was an insult to the tissues of the airway itself. Mild or partial airway obstructions are when a patient can still exchange air, but they may have some respiratory distress. This is noted by noisy breathing, wheezing, coughing. Oftentimes, a sense of panic will ensue over these patients, and they may scream and ask for help, as they should. With good air exchange, So if they are ventilating appropriately, even with a partial airway obstruction, do not interfere with the patient's efforts to expel the object on their own. The body does a really good job at self-preservation, and the coughing that's occurring or the gagging or emesis that may be occurring is aiding and assisting that patient in helping remove that airway obstruction. So encourage them to cough if there is a mild airway obstruction. With poor air exchange, the patient may have an increased difficulty in breathing. You may note cyanosis on your assessment, or you may hear sounds such as stridor. And stridor are coarse airway sounds notable from an upper airway obstruction. For these patients, you should treat immediately. Severe airway obstructions, oftentimes patients can't breathe, they can't talk, and they can't cough. The patient may use a universal distress signal, and that's the hands grasping around the neck. They may also begin to turn cyanotic and have extreme difficulty breathing. For severe airway obstructions, you need to provide immediate treatment to the conscious patient. And we'll talk about abdominal thrusts and the Heimlich maneuver when you take your BLS course, which is our primary course of treatment, until the patient becomes either expels the occlusion of the airway and are able to regain spontaneous ventilation, or they become unconscious, at which time you'll start CPR for that patient. If the patient is unresponsive when you arrive and not breathing, you're going to begin chest compressions. First event for emergency care for foreign body airway obstruction is to perform a head tilt chin lift maneuver to try and clear the tongue as the airway obstructions. Sometimes you can visualize the obstruction in the mouth, and if you can see the instruction, you should use your fingers and sweep forward the obstruction out of the mouth. Abdominal thrusts are the most common and effective method of dislodging and forcing out an object in the conscious patient. Some other common inclusions may be dental appliances, and again, head tilt chin lift for the patient to remove the tongue, and then inspect the airway. This is why it's important that we visualize the airway to make sure that it's patent and identify obstructions. If you see dental appliances in the mouth that could be causing a potential airway obstruction, you should remove them. You should always remove them prior to providing positive pressure ventilation or ventilatory assistance for a patient. If the patient has well-fit dentures or the oral appliances are attached firmly in place, you don't need to remove them. Facial bleeding, another common airway obstruction, can be challenging with patients because facial tissue is profuse with capillaries and can bleed heavily and significantly, particularly in the instance of trauma. This can create problems not only with creating adequate seals or delivering ventilation, but you may have to provide near continuous suction to make sure that you can keep the airway clean to be able to ventilate appropriately. If the bleeding is from a visible source, so for example on the external area of the face, you can control that bleeding with direct pressure and you can suction the airway as necessary. For patients with significant airway obstruction, they're very likely going to need additional assistance from advanced procedures. So you should be prepared if you're with a paramedic on an ambulance or if you've called for ALS backup to get equipment set up, to be prepared for advanced airway procedures such as intubation, and be familiar with the next steps in that process. One acronym that can be used is B-MAGIC. B for perform bag valve mask ventilations and pre-oxygenation. E, evaluate for any airway difficulties. M, manipulate the patient utilizing a head tilt chin lift or jaw thrust maneuver. A, they may attempt the next first pass intubation. G, use a supraglottic airway if unable to ventilate. And C, confirm successful intubation and correct any issues that may arise. Your familiarity with this product will ultimately help the patient in the long run, as you're going to need to serve as an assistant to the paramedic or the advanced provider that's performing these advanced airway skills.